Now we will have a talk from Dr. Devesh on acute retinal necrosis.
Thank you, sir. So, acute retinal necrosis is a peripheral necrotizing retinitis that has a characteristic appearance and a course which occurs predominantly in immunocompetent patients, and it is caused by HSV or VJV commonly. Now, if we see the epidemiology here, most commonly it occurs because of varicella infection, followed by herpes simplex, and then very rare reports exist of CMV as the etiology for ARN as well. Now, majority of the patients will be immunocompetent here, but rarely again patients who are immunocompromised, such as those with HIV or those on immunosuppressants or with hematological malignancies, could also develop ARN. Now, the ARN which occurs in such immunocompromised patients, it has a different clinical appearance and course as compared to those who are immunocompetent. Males and females, they are equally affected, and now there is a bimodal presentation that happens because of the difference in the etiological agent. So, majority of the cases are about 50 years of age, will be the median age is around 50 years, and the infection is because of VJV or HSV1. And in younger population, because of HSV2 infection, it can be around 20 to 25 years of age. Now, how does the viral infection reaches the retina? It is not very clear, but it is presumed that it occurs because of a retrograde transmission of the virus from the ganglion which are there. Predominantly, it is considered that it is the ophthalmic divisions of the ophthalmic division of the trigeminal nerve or the maxillary division of the trigeminal nerve. Through that, it comes to the eye. Now, the virus reactivation, it can occur years after the primary infection, which could have been a subclinical infection, or in certain cases it could occur with the systemic infection in the primary setting also, such as those patients who have herpetic encephalitis or dermatomal zoster. In those patients, sometimes you can have primarily viral infection in the eye as well. Now, there are two distinct phases of ARN. In the acute phase, you have virus-induced cytolysis, and that leads to an inflammatory response which damages the retina further. And you also have arteriolitis, and that leads to occlusion of the capillary network, and capillary non-perfusion happens, which then profounds the retinal damage. Now, in the cicatricial stage, what happens? Because of the acute phase, there is a lot of cytokines that are released into the vitreous cavity. Now, these cytokines have an effect on the RP and the fibroblast, and membranes form and they contract. And in addition, there is necrosis of the retina. So, these membranes, they contract and act on these breaks to cause retinal detachment. Now, three cells are predominantly involved here with the infection, and cytolysis affect all of them: the neurons in the retina, the RP layer, and the vascular endothelium. It's a full thickness necrosis that happens in the retina, and there is fibrinoid necrosis in the arterioles as well. Now, coming to the case, a peculiar case in which a 39-year female with no systemic illness presents with a 4-day history of mild pain and some blurring of vision. So, this won't be the usual presentation, but this is how usually the ARN will start with. And the patient had 2+ cells in the anterior chamber with few retrolental cells. If you see the posterior part of the fundus, it more or less seems normal. So, unless you do a dilated examination and inspect the periphery, you are going to miss such cases. When you see the inferior periphery in this patient, you can see there is a confluent patch of retinitis inferiorly, and there are small other patches which are present in the periphery. There is minimal hemorrhage. There is not much vitritis at this time because the presentation is very acute. And you see the other eye is perfectly normal. There is some white without pressure area over here. So, the manifestation is mostly it's a pan-uveitis that happens with sudden onset and acute course. Usually it is one eye involvement at presentation in most of the cases, and the fellow eye can be involved if not treated in up to 1/3 of the cases. The progression, as I have told, it begins as if it is an anterior uveitis, but if not treated within 2 weeks time, the classical triad, which is peripheral retinitis, occlusive vasculitis, and vitritis will happen. The peripheral retinitis has scalloped margins, and retinal hemorrhages are very few. Most likely, you will see patients who will present with this picture, in which there is confluent patches of retinitis which are spreading circumferentially with lot of vitritis. So, this is a very common presentation. Other common presentation could be an annular involvement, in which the presentation is more delayed, lot of vitritis, and the lesions have spread annually, and they are now progressing posteriorly as well. And this is a patient with HIV who had extensive involvement but not much inflammation. Now the diagnosis is till date, till 2021, when Sun gave the diagnostic criteria, revised diagnostic criteria, it was a clinical diagnosis, basically including one or more foci of retinal necrosis with discrete borders in the peripheral retina, rapid progression in the absence of therapy, circumferential spread, occlusive vasculopathy, and prominent inflammation. Now, rapid progression will be noted only on follow-up. So now Sun working group has removed the rapid progression, and it says that any peripheral necrotizing retinitis with either a characteristic appearance and course, or you can have atypical cases in which you may not have a characteristic appearance and course, but still the PCR of these patients could be positive for HSV or VJV. So these will also fall under acute retinal necrosis. Now they have removed the rapid progression and they have included the use of PCR. Important here that they have included in the diagnostic criteria that positive syphilis serology test is to be considered as an exclusion criteria. Now, diagnosis could be supported if there is systemic herpetic infection and it can be confirmed with the presence of viral DNA either in aqueous or vitreous. Aqueous sample is as good as vitreous, and the positive, the sensitivity is as high as 100%. So you get a very good PCR report in such patients. The load is also very good. So, but the PCR, although it is confirmatory, you should not wait for the PCR result to come. You should immediately start the treatment in typical cases. Now, differentials, CMV retinitis, will come to that later on. Toxoplasma, we have already told in atypical cases, Dr. Shaurya had shown that atypical cases, you need to look the fellow eye also. There could be some choroiditis scar which could be there, and then on doing the serology, it came out to be a Toxoplasma retinitis. Then syphilis is a great masquerader, and the incidence of syphilitic uveitis and retinitis is on rise post-COVID, and there are lot of cases that could be in the advanced stages, they could be confused with ARN. So this is a typical presentation of syphilis in which you have placoid lesion along with these characteristic punctate inner retinitis lesions which are there, but in advanced cases you will have extensive vitritis along with some retinitis lesions. Now in this state you can confuse it with ARN, and if you treat with antiviral therapy alone with oral steroid, this is likely to worsen with time. So a serology for syphilis should be done in all atypical cases where you are suspecting ARN. Now investigations, normally these are not required, but peripheral OCT, yes, it can help you make out whether it is a full thickness retinal involvement or predominantly outer retinal involvement or retinochoroiditis with hyaloidal thickening that can happen in Toxoplasma retinitis. In late phases, it can help you make out retinal detachments and retinal breaks. And if you see in this case, there are a lot of retinal atrophy which is happening in the periphery, and retinal detachment is there, and there is residual opacification of the retina in between, and adjacent areas are thinned out retina which could be seen in on OCT. The treatment is aimed at treating the affected eye as well as preventing the infection in the fellow eye. So it is important that you timely treat these patients. The classical regimen is that you used to give intravenous acyclovir 10 milligram per kg 8 hourly for 10 to 14 days. And that to be followed by oral acyclovir for next 6 weeks to 3 months for preventing infection in the fellow eye. So the induction phase is aimed at treating the affected eye, and the maintenance phase is to prevent infection in the fellow eye. But then there are some modifications, we'll come to that. Anti-inflammatory treatment, oral steroids are very important, and you need to start them 24 to 48 hours after the antiviral therapy has been given, and you see some response of antiviral therapy, then you add prednisolone. And topical steroids in cycloplegic may be required for anterior uveitis. The role of aspirin is very controversial. Some people think that it helps in preventing the occlusive phenomena that happens with arteriolitis. Now, alternative therapies could be in the induction phase. You can use oral valcyclovir, which has a very good bioavailability. 2 grams TDS is equally efficacious to intravenous acyclovir. And alternate maintenance therapy could be oral valcyclovir, 1000 milligram TDS, or maybe once a day for different etiological agents. Now, the bioavailability of these drugs is so good that you need not give intravenous therapy for these patients and need not admit these patients. But then the downside is the cost of these medications, which is very high. The regression, it usually starts from the peripheral edge, and there is some salt pepper pigmentation. So after 8 weeks of treatment, you see that the retinal atrophy has developed here, the opacification has resolved, and later on breaks can also form in such retina. The slides are not moving. Okay. So this was a case of bilateral ARN, and at 2 weeks the disease has started consolidating, and it's 4 weeks in the left eye you see there is a retinal detachment which has happened, and in after surgery the retina is well settled, and in the right eye at 10 weeks the retinal detachment has happened. So retinal detachment happens in around 75% of the untreated cases mostly between 6 to 12 weeks, and the treatment is aimed at internal surgery with vitrectomy and endolaser and siliconal tamponade. The complication other could be an optic neuropathy that happens in 50% of the cases. Now, prevention of the fellow eye could be done, as I told, by extended antiviral maintenance therapy, and retinal detachment. There is not much proven role, but possible benefits could be with the combined intravitreal therapy and prophetic laser or early vitrectomy. Now, the meta-analysis studies recently published do not support the role of either prophylactic laser or prophylactic vitrectomy, but these are being explored. The downside of these meta-analysis studies that they have mainly concentrated on there are only retrospective cohort studies, there are no prospective controlled trials. To conclude, ARN is a rapidly progressive necrotizing retinitis that is caused by VGV or HSV. It might be overlooked in the early stages and may be mistaken in the late stages. Syphilis remains an important differential, and prompt treatment is required, followed with oral steroids, 24 to 48 hour laser. And retinal detachment commonly occurs in untreated cases and may possibly be prevented with prompt and antiviral therapy along with oral steroids. Thank you.
Thank you so much, Dr. Devesh. So, very nice talk. Just to add, my personal preference for treatment, I now go for 2 gram TDS valcyclovir. I have personally not tried intravitreal ganciclovir, but I have been reading now lot of literature where people say that adding on intravitreal ganciclovir, although ganciclovir more for CMV, but it also acts on this virus because in vitro it has shown activity and it may reduce chance of redetachment. But personally, I have not used it in many cases. Maybe we can try. And role of laser, like he rightly mentioned, we generally say avoid laser, but sometimes when you see those large thin areas and you feel very scared, you take an optos photograph, then sometimes we have added laser. I think he quickly showed that photograph because of lack of time. But if you do laser, please do it in normal retina. Don't do it in the thin retina. You do it at the normal edge and do a wide laser from ora to ora in the normal retina. Don't go and laser the thin retina, either you might create a break. Anything, Dr. Will? Any questions or any comments from the audience? Thank you so much. So, yeah.
From a general ophthalmologist point of view, how long do you continue this valcyclovir for ARN, and how long do you continue the Ceftran DS in cases of toxoplasma?
So for ARN, usually the induction phase is to be ideally be continued till the consolidation of all the lesions is there. So usually that will require 2 maximum 3 weeks of therapy, and sometimes if it doesn't resolve within 3 weeks, then you may continue it for a longer duration also. But the maintenance therapy will again depend on the immune status of the patient. Usually 3 months minimum, because majority of the fellow eye involvement will occur within 3 months, but people have given it for 6 months and up to 1 year as well.
And for toxoplasma,
Toxoplasma, we had already discussed that toxoplasma we might again based on the immune status, but people are giving it for 1 to 2 years also, and they've seen reduced recurrences. But as told by Dr. Rohan, in our setting, we have not seen much recurrences ourselves.
Immunocompetent patients,
So immunocompetent patient, normally in the first go, we do not continue it beyond the routine, but in immune compromised patients, yes, you need to give it for longer or maybe lifelong.
No, we are not routinely using aspirin. No, we are not using. Thank you.